Hey everybody, welcome. I'm Jaspal Singh. On behalf of CHEST, I'd like to welcome you all to our webinar. And we're going to be talking about lung cancer and the COVID-19 pandemic. So with me today is Dr. Katie Milam from Charlotte, North Carolina, and we'll kind of go through introductions together. Again, I'm Jaspal, and hopefully this will be an educational webinar, an educational session for you that you'll enjoy. So today's objectives, we're going to review the impact of the COVID-19 pandemic on lung cancer management and evaluate best practices for maintaining continuity of lung cancer care, discuss the importance of screening, accurate lung cancer diagnosis and staging, and the need for timely referrals. We're also going to highlight the key benefits of a multidisciplinary approach in lung cancer management and review treatment advances. And the underpinning of all this will be in the setting of the pandemic and how things are evolving in this current state. Again, I'm Jaspal Singh. I'm at Atrium Health in Charlotte, North Carolina with Levine Cancer Institute. I'm a pulmonologist and advanced bronchoscopist. Katie, you want to introduce yourself?
Absolutely. So my name is Katie Milam. I'm a medical oncologist specializing in lung cancer, and I lead our thoracic medical oncology division at Levine Cancer Institute in Charlotte, North Carolina. It is absolutely my pleasure to join everyone today. Thank you.
Thank you for joining us today, Katie. And a disclaimer, this presentation is supported by AstraZeneca. It's meant to provide educational information on how to optimize lung cancer management during the pandemic. And this presentation is unbranded and does not discuss or promote any investigational or approved drugs and does not refer to drugs by their brand name or commercial entities. The information in this program is consistent with FDA guidelines, and the program is not CME accredited and may not be used for CME accreditation. So let's talk about lung cancer screening and diagnosis. And I think this is sort of an area that a lot of us are interested in. And we know that lung cancer is the leading cause of cancer deaths, but that diagnosis at an earlier stage and timely treatment can improve outcomes. And almost a quarter of all cancer deaths in the United States are due to lung cancer. And we know the survival rates are not so great when it's more distant disease, actually, and especially even in regional disease. So the idea of finding localized disease early in the disease course is oftentimes best. So I think most of us know that. And I think the idea of screening is particularly exciting in the last several years, as many of you across the country have instituted or are instituting now lung cancer screening programs, just given the changes in the screening guidelines. And those have been expanded recently. But the idea is that the general population, stage 1 is a small percentage of lung cancers. And the idea that screening can detect many more lung cancer at an earlier stage, and actually overall, from a population perspective, if we find lung cancer through screening programs, we can get a substantial reduction in mortality through the NSCLC trial that showed some of this, and other trials that have added to that body of evidence. Now, what happens to screening during the pandemic? So many of us, I'm sure many of you on this webinar also, had to really seriously look hard at your screening programs. And a lot of us either shut down or delayed or really stopped screening for several months, especially in the early parts of the pandemic. So this graph shows that the number of lung cancer diagnoses in 2020 versus 2019 substantially went down. And that's probably because a lot of people stayed home, they didn't go to their doctor, they didn't go for their screening programs. And so that idea of lung cancer screening shutting down early in the pandemic is important. Now, as this data is from from March to May 2020, and so some of us, such as in Charlotte, North Carolina, had not even hit our real peaks yet. So I expect that this data will be coming out showing a substantial reduction in overall screening and incidence during that course. And so unfortunately, that likely means that we're going to see a delay and more advanced stage, which we'll talk about in many parts of the country. Now, as the pandemic plays out, many states have had a recurrence, and we'll see how that changes the overall incidence and prevalence of lung cancer. So how has the COVID-19 pandemic impacted the journey through lung cancer? Well, early on, we already had problems early in the pandemic, prior to pandemic, I should say, where a median of almost 5 weeks, or in many places, at least 3 weeks, between the time of presentation and diagnosis and confirmation. Because think about what patients have to go through, from screening to presentation to testing to diagnostics to treatment options being discussed. By the time they actually start treatment, it can take weeks to get started. That was even before the pandemic. Now we've all seen reduction in referrals, the screening visits, elective procedures, for a lot of reasons, which we'll get into. And then comes the other big part, is that the same patients who are eligible for screening, or the typical patient with lung cancer, is also that patient that potentially fears getting COVID-19 the most, or has potential risks of acquiring significant disease burden. So from that perspective, they're less likely to go on to see the doctor. They want to go through invasive testing. They're not going to want to go through pulmonary function testing unless they are assured that they can be safe. And we want to make sure that we provide that safe environment. And on top of that, if they get COVID-19, they're more apt to be at higher mortality. So you couple those fears and the actual data of the risk of the disease burden, you can see the significant impact here. So I think a lot of us now are seeing our screening rates are coming back up again, but we're going to hopefully see a continuing ongoing increase, but we also had to be cognizant that we're going to see some symptom overlap and may be harder to detect these patients earlier on than perhaps we even thought about. So what will be the impact here of timely referrals, accurate staging? Let's talk about that a little bit. So pre-pandemic, we know stage at the diagnosis of non-small cell lung cancer, and from stage 1 to 3 and stage 4, we had a lot of stage 4, but we're going to potentially see an increase in the number of patients with post-pandemic who have a more advanced disease. And so they're less likely to be resectable or have curative intent. And so from this perspective, the pandemic is going to substantially change how we approach lung cancer in general, both non-small cell and small cell. The other part of the aspect of diagnostics is the idea of trying not only finding out how advanced the disease is, but also they have to go through a series of testing. From on the left side, pulmonary function testing. Well, that's an aerosolizing procedure. A lot of us had to reevaluate our pulmonary function test labs, and we're still reevaluating them as to how safe they are, how many tests you can do in a day, how easy it is to get a test that it can aerosolize the virus. So we had to think about that part as well. Also, the staff availability and the staff comfort. Same with the X-ray, same with imaging. Our CT, radiology colleagues, PET colleagues had to all think about how they're going to adjust their safety protocols and such. And so we had a little bit of a delay in all these aspects in the diagnostic tools. Our pathology team, the same pathology team that was actually helping us with lung cancer biopsies and interpretation, were also challenged with some of the molecular testing for COVID-19 assays. So the lab throughput was also adjusted. The surgical evaluations, so many hospitals around the country had to shut down from what were considered non-emergent surgeries. And so that affects the entire operations of a patient's journey. And so even determining resectability was challenging, especially in the early parts of the pandemic, but it was extremely critical. And so the importance of mediastinal staging, as a pulmonologist, I felt this was something that I had to really wrestle with, and I think a lot of my colleagues did too, as to how invasive do you get in the midst of a pandemic? A lot of us had for years known that you cannot rely on just radiographic imaging like a PET CT to stage people. And so invasive staging was sort of our standard protocol and procedure for many patients who even though may have resectable disease. And so mediastinal staging was important, but now you have to ask yourself, how important is it? Do I put my patients through or myself at risk for potentially doing an invasive procedure? And I think once we figured out how to do that, I think a lot of us are very comfortable doing that. But for a little while there, we had to really ask ourselves some hard questions. But we're back to where mediastinal staging is part of the workup, and we're back to our usual care standards. So early on, a lot of us struggled with these questions, and so several societies, including the American Association of Bronchoscopy, Interventional Pulmonology, the Society for Advanced Bronchoscopy, and a number of us developed some additional guidelines knowing these concerns were out there. And so we initially were a little bit fearful of bronchoscopy, but over time, within a matter of weeks, many of us, once we were assured that we had enough personal protective equipment available and we could do this safely, we basically started really becoming comfortable going for bronchoscopy when we needed to when we needed to do it. So just thinking about the lung cancer patient during the COVID-19 pandemic, one of the important aspects is biomarker testing. And I think as a pulmonologist, we've finally gotten our groups of pulmonologists and other proceduralists, radiologists and such, becoming more aggressive with getting enough tissue for molecular testing. So all of us had really worked hard in the last several years to really make that part of our culture. But now it becomes the aspect of how do you do it during the midst of a pandemic? And so we started thinking about liquid biopsies or other means of answering the important questions of biomarker testing. We're still working through that, but I think a lot of us now are back to doing invasive biopsies. Multidisciplinary discussions. So like many of you, some of those of you who have access to tumor boards, I loved my tumor board, for example, going in there, listening to a lot of people talk, people that are smarter than myself, kind of debate different options. But now I had to sort of think about, it all went virtual. So do I join into another Zoom call? Do I go into another webinar? Do I put up my phone? How does that feel? And how do I develop that communication? And I think a lot of us switched to a virtual platform, and I actually like parts of it. So we'll see how much that stays. But the idea was multidisciplinary discussions here were so key because this work is complicated. Decision-making has major implications, and so making that best decision up front is important. I have a couple of questions here. I'm just going to quickly answer a couple of them and the questions right now. What advice would you have to other PCPs or clinicians who may have patients hesitant to follow up for regular screening? I would say just check in with your local pulmonologist. What we've gone back to is we've started slowly opening. We've answered patients' questions. We've been reassuring patients that our offices are safe. We've been reassuring that our radiology procedures are safe. So we've been becoming much more aggressive about making sure patients feel reassured and that letting them know that we are trying very hard. We also recommend patients get vaccinated, which we'll get to at the end. How often are you doing invasive staging for an accurate diagnosis to gather samples for biomarker testing? So biomarker testing for pulmonologists is actually incredibly easy if you have a fairly large target. So if we have fairly large targets and we're already doing a procedure already, getting additional tissue for biomarker testing is actually part of what we do. And if we don't get enough, we try to make sure that we have certain standards. So if you want to share a protocol, feel free to email me. I'm happy to show you our protocol of what we do, but several passes through with decent sized needles or other adjunctive technologies for biopsy, we're happy to sort of share that information. But yes, we do biomarker testing. So moving on, multidisciplinary teams. And I said those last two questions kind of got back to the idea of team-based care. And I think team-based care is more likely to recommend recommended therapies. And that's true for cancer. That's true for anything else I do. I'm a pulmonologist, so I deal with pulmonary fibrosis. I deal with other complex lung diseases. And every time I always come back to the idea that team-based care is always better than whatever I desire. The idea of being able to talk through things, challenging situations, get around people that are like missioned is very important. So data have shown that basically when an oncologist makes a decision versus oncologist plus radiation oncologist plus additional people, that the chance of guideline directed care is far greater. Katie, do you have any thoughts on that?
Yeah, I mean, I'm listening to all of this, and I absolutely agree with you. I think that one of the benefits that you can have in whether it's guideline based or just having that multidisciplinary discussion, and you find the people that you trust, whether they don't have to be necessarily within your practice. They can be colleagues down the street via internet. And one of the advantages that we've learned with COVID is the ability to connect with people locally, regionally, nationally, that we trust across all disciplines. So I think that there's just a tremendous ongoing opportunity to expand those areas of guidances and communication to provide excellent care.
I totally agree with you. Even before the pandemic, about a quarter of patients never even received treatment. Many are not even offered treatment. And then for extensive stage small cell lung cancer, about a third do not receive treatment. That was before the pandemic. So now you add additional challenges with the pandemic of patients basically not wanting to go see the doctor, the fears of being seen in a healthcare facility, getting treatment. Many of my patients were scared of any kind of treatment whatsoever, whether it be medical, radiation, or surgical treatments. And so the additional fear, we're worried that a lot of patients went without treatment. And so it becomes very challenging. And we'll talk about, even if you get treatment, monitoring the side effects becomes challenging, which we'll talk about a little bit. So can't stress enough the idea of multidisciplinary care and putting the patient at the center. And as I get older and grayer, it seems like more and more to me, one of the biggest issues in healthcare has been that we have not traditionally put the patient at the center. We put the disease at the center, or we put the physiology of some sort in the center. And that's not how we want to practice. So we moved incredibly hard at this paradigm shift. But again, everyone has different teams. And so depending on your practices and what that looks like, it's going to look a little bit different for you. But I encourage you to actively seek those, as Dr. Milam says, Katie said, those who you trust to be in this, people who are like missioned. So the lung cancer patient journey, in terms of biomarker testing, virtual tumor boards has increased. And I think a lot of us now, I personally like the virtual tumor board because I can do that if I'm not having to rush to the Bronx Suite in the morning. I can actually put it on my way in or listen to it while I get breakfast ready. Ours are early in the morning. The lunchtime ones I can do in my office while I'm doing other things. And so the idea of virtual tumor boards is important. I think hopefully the pandemic will ease that. And the idea of it being more sort of virtual multidisciplinary in its approach. And so now people are very comfortable just opening some app on their phone that they can sort of dialogue with or communicate in some other virtual platform. So we'll see how that goes. And I think for many of you, it's going to be some experimentation of how we did business a little bit differently now. So with that, I'm going to turn it over to Katie. Talk to you. Can you talk to us about treatment advances in lung cancer?
Great, thank you, Jaspal. That was a great introduction. And I'm going to kind of shift. We're still going to be focusing on the COVID element, but really focusing on treatment advances in lung cancer. There were plenty of things that were happening in the midst of the turmoil during the pandemic, and we were still making tremendous strides in treatment for lung cancer. So we're going to first provide some updates on treatment advances, and then focus on how we adapted, and really how do we use the adaptations towards advancing the care for the patient even further. So this is, to me, just a really impressive slide. And for anyone who has not seen this in graph form or numerical form, take a look. The US cancer death rates have dropped 31% since 1991. And really a lot of that has been driven by declines in lung cancer mortality. And in fact, lung cancer mortality accounts for almost half of that total decline in all cancer mortality between 2014 and 2018. And what's most impressive to me here is what we can expect in the future. Many of these declines occurred prior to the utilization of immunotherapy in lung cancer. So we really can't even attribute these benefits yet to all of the impact we have seen with immunotherapy. I would say that most of this is due to advances in treatment with targeted therapy, as well as some improvements in smoking cessation, as well as screening, which Dr. Singh has already alluded to. So advances in treatment have really spanned all aspects of the way we approach treatment of lung cancer. It may not be a systemic treatment. It may be something that is local regional in our radiation techniques, our surgical techniques, also combinations. But importantly, these numbers are so impressive. There have been more than 20 indications in each of these subtypes of treatment management, about 20 in the IO space and 20 in the biomarker space in lung cancer since 2014. So, despite the challenges that we were up against, we really continue to push the bar and elevate the care for patients. So I think what's really important, and we are emphasizing, Dr. Singh and I work together all the time and have a very collaborative atmosphere. But I really want to emphasize with this and with this whole discussion today, why that is so important. And even from my perspective, why I really continue to trust and rely on the primary care physicians and the pulmonologist. I look at cancer care not as a passing of the baton, but really as that ongoing collaboration. Because there are limitations to what the medical oncologist can continue to manage at an expert level. And so that has to do with not just the chronic illnesses that maybe initially brought the patient to the pulmonologist or the primary care physician, whether that's COPD, chronic illnesses related to smoking or other exposures. But when we start treating patients with lung cancer, there are many side effects of treatment and toxicities just related to the cancer itself that require that ongoing management. And it takes, just knowledge of the possibility for these just to engage that collaboration. Specifically, I'll just point out pneumonitis, and this is not just an immunotherapy toxicity. It's also something that's associated with targeted therapies as well as radiation. And in many cases, we're utilizing some of these modalities concurrently. And so it can get very complex, and the need to continue to talk about, what do we think is related to the immunotherapy versus the cancer? How can we manage that? How can we optimize management of pleural effusions? And really with the goal of maintaining the patient's performance so that we can continue to engage in their cancer management. And I would ask Dr. Singh to weigh in from his perspective on how this impacts his practice and maybe even how that changed during COVID-19.
Yeah, thanks, Katie. So I guess the couple things come to mind. I think the idea that treatment is challenging and that, it definitely highlighted what I think a lot of us took for granted. The pandemic it's very easy to get patients in the office. Before the pandemic, we would get patients have a problem, come see us in the office. We'll get some x-rays, we'll get some pulmonary function testing, we'll get some evaluations. If you have an other issue, respiratory failure, we can move you through the network pretty easily. I think we need to come back and really step back and say, how are we navigating through this? So our navigators, our other aspects, our other staff, and for those who don't have navigator access, might want to sort of reach out to their nurse, had to make sure that they have some means to touch that patient or to examine the patient when they needed to do. And as you know, I'm a huge telemedicine advocate, but telemedicine has its limitations. As much as I love it, in terms of frequency, the ability to do a lot of things, I also look at scans regularly through my home computer and such. But at times, you just need to sort of look at that patient, examine them, and understand them. And I think the complexity of the disease processes themselves and the pandemic coupled with that has just highlighted the importance of really emphasizing communication and making sure that patients know that we're there for them.
Mm-hmm. Absolutely. Yeah, communication is really a key component to this. It can be difficult depending on your office setup or your hospital network system. But I think just with technology, it's much easier to facilitate that. So my main line there is that we definitely continue to rely on the expertise of the other specialists to engage and optimize patient care in this setting. Thanks, Jaspal. So just to give people an idea of where we are with resectable disease, I'm just going to kind of give some high-level updates on our patients with resectable non-small cell lung cancer, and then I'll go into the unresectable space and even just touch on a little bit of small cell, just so that we can understand the scope of where we've been and where we still need to go. So, it's important to recognize that it's really only about 20 to 30% of our patients with non-small cell lung cancer have resectable disease. So there are, I think what's also really impressive to me when I think about where we need to continue to improve outcomes is you can look at this graphic on the right of the screen that demonstrates recurrence or death within 5 years and just see that stage by stage. And to still see that nearly 50% of patients with a stage 1B resected non-small cell lung cancer have a recurrence or death. It's just a very impressive number and demonstrates and just emphasizes an ongoing need to make advances in this space. So, EGFR mutations, if we think about, we've all heard about that. What is an EGFR mutation? What is it really doing to the tumor space? what leads to an unregulated proliferation and survival of those tumor cells. And it becomes a key driver of that disease, and that's regardless of the stage. So we know that that's driving that tumor proliferation, and it's not just unique to EGFR. We know that there are other tumor aberrations, whether that's ALK, ROS1, BRAF, all behaving in a similar pattern. We also already know that the prevalence of EGFR mutations in stage 4 disease in the metastatic setting is about 20 to 30%. I'm not sure if you really realized that prevalence is similar across all stages. That's not unique to metastatic disease. That is just where we tend to have more data, more agents, more FDA approvals, treatment paradigms. But it's still stage 1, 2, and 3 have that similar prevalence in that 20 to 30%. And so we have to consider how that driver mutation, the EGFR mutation, may impact our treatment options and recurrent patterns in that space, specifically in our resectable patients. So there are NCCN guidelines that have been updated that do now recommend molecular testing for EGFR mutation. This is not, the broad panel, but specifically for the EGFR mutation in patients with completely resected 1B to 3A non-small cell lung cancer, because it truly may inform adjuvant treatment decisions. Very important.
Yeah, another thing can I just add real quick? I think this gets back to one of the audience members' questions about how often do we do invasive staging. We do it a lot. We do it at various parts of the course. If someone has a initially early stage, then ends up with progression, we have very low threshold to do invasive staging, because just for these exact reasons that you outlined.
Yeah, it's most of my patients know that I kind of set that stage up front, that in order to provide what I would consider to be their best care, part of that, just like a CT scan, may include getting a biopsy. And what we've learned is that there are mechanisms of resistance that evolve over time. And to understand that path is really important, because there are additional opportunities that may further direct that therapy. So in thinking of our patients with unresectable stage 3 non-small cell lung cancer, it's really important to understand, and I think most of the message here is that we are still trying to cure these patients. And I do tell, my patients very clearly when I speak to them, outside of the metastatic setting, that our intent, albeit challenging, is to still provide curative therapy. And the evolution of management of something that cannot be resected has come much farther recently. Initially, a patient with unresectable disease would get radiation, and that provided some benefit, but not very high and rarely cured in that setting. And then the addition of chemotherapy in a sequential fashion to radiation did provide additional benefit by getting some radiation sensitization and killing your micrometastatic disease. It was really with the onset of doing that in a concurrent setting rather than sequential, with standard dosing radiation up to 60 gray, and there are various studies looking at different radiation goals there, provided about a 32% 5-year overall survival. So still an advancement. I mean, you can see that that's a tremendous advancement from sequential, just bringing it concurrently. So it really speaks to the truth and reality that this is not enough. And it's very hard to, even though you're saying to a patient, my intent is curative, when you look at these numbers, it's a very challenging option and attempt at opportunity. So, it's just, I think it's, despite our progress, recognizing that more than half these patients are going to progress to metastatic disease with even what we would have previously considered our standard is real disappointing. And so this brings me to the unresectable space with the ability of adding consolidative immunotherapy after concurrent chemoradiation with definitive intent. And this is regardless of lymph node status. So you can see these updated NCCN guidelines that for stage 3A, 3B, 3C, unresectable non-small cell lung cancer. So moving on into the metastatic space, we've already alluded to this, right? This is, we lean on our interventional pulmonologist to, basically get as much tissue as you can, because this is the world that's expanding in the metastatic space. This, just shows you the distribution of druggable, targetable driver mutations within lung adenocarcinoma. And although KRAS currently does not have an FDA-approved targeted therapy, it's one that is making tremendous advancements, and that we look forward to the expansion in that space. But the rest of the pinwheel actually has not just one, but multiple targeted agents representing each one of these. EGFR is the most common. ALK, ROS1, BRAF, MET, RET, TRAC fusions. All of these have FDA-approved agents, and I think it's really important that if there is an opportunity for a patient to be treated with targeted therapy that's specific to what is driving their cancer, that they have an opportunity to receive that. And the only way that they're going to have that opportunity is if we have tested for it. And the only way that we test for it is oftentimes with tissue. And so being able to get that, although the liquid biopsy is certainly an area of expansion. And so it's not just the driver, it's also PD-L1 status. Regardless of how we feel that this provides, this acts as a good biomarker or not, it certainly has been predictive of response and to the immunotherapy paradigm. So it's not just checking for these driver mutations, it's also checking the PD-L1 status. And I'll just emphasize how crucial it is to have this information up front prior to initiating therapy. I think a lot of times, people get anxious about wanting to treat their patients. And it's, if they're not symptomatic, I think it's important to be able to kind of put a pause and ensure that you have all of the information up front. And so oftentimes I will just, tell my patients we're getting as much information as we can up front, so that we can make sure that we're making an informed decision. So for small cell, just a really challenging cancer, extensive stage, or all small cell lung cancer. It's just got such a rapid proliferative rate, and the ability to spread and grow because of that rapid proliferation. It's just associated with such a poor prognosis. And with that, most cytotoxics, if you think about how chemotherapy works, chemotherapy gets into cell cycle. And if you've got your cancer cells that are always in cycle, that's why we have such a tremendous response to chemotherapy. So small cell is very chemotherapy sensitive. However, it's just tricky because that response is not durable. And the majority of small cell, even with an initial response, does recur. And with that, even later lines of therapy become less and less effective. And so it's just tremendously important to ensure that we can bring our best therapy to the first line. This chart on the right, and see that, almost all patients relapse within the first year, and it's even sooner than that. We're talking within months of completing that initial treatment, and it may even be while they're on that initial treatment. So the overall survival, even for a patient that responds to treatment that has been diagnosed with small cell, is very low. And so bringing immunotherapy into the first line setting by not just using immunotherapy in later lines, but again, using it in the frontline setting in combination with your platinum etoposide. So how did this change, in COVID? Well, I think that really everything is always on a case by case basis, balancing that risk with the risk of lung cancer progression. I mean, one of the challenges I felt was lung cancer was right up there. We've got people that have a lot of comorbidities, whether it's COPD, they're already oxygen requiring, they are long-term smokers, they have damaged lungs, then they have lung cancer. And then we're balancing that risk of a cytotoxic with suppression of their their immune system, and then running the risk of COVID. And so what was safe, what should we hold and what should we continue? I will tell you that the majority of my actions were just continuing to treat the cancer, continuing to treat the patient. Death from lung cancer is real. We've looked at that today. And so needing to ensure that we were being safe and diligent and continuing to recognize the merit in treating the lung cancer. And so what that did was it changed to utilizing reduced exposure. If we could switch to an oral from an IV, for example, if there's some formulations that are IV that are given daily 5 days in a row, but have an equivalent oral formulation, then absolutely we were using an oral formulation. If we could use a different regimen that had 3 days of IV infusion rather than 5 days of IV infusion, then we would make those adjustments just to reduce traffic, reduce exposure. But I think, what was important for me was to continuing to be present and continuing to show our patients that we were here for them and that we were going to try and guide them. From a surveillance perspective, it provided an opportunity to have conversations. If you were asymptomatic and you were, it was time for you to maybe change your interval of surveillance. It created some conversations about, risk of recurrence and altering that. So I think there were a lot of opportunities to rethink how frequently we're scanning people. I think that we all thought about barriers and prioritization. I think one thing that I looked at was how many people really need a port. If people are just putting ports in because they're giving an IV chemotherapy, but it's an irritant, not a vesicant, or maybe they already have good vein access. Do they really need that? One of the issues I ran into was oxygen tanks. And so I had a lady who was on hospice who was not able to receive her oxygen. She was able to, but there was an inherent delay. And it really opened up a conversation to readdressing comfort needs and how we were going to balance that. So, thinking of resource allocation and just changes in service availability. And then just addressing patients' fears and just helping them and listening to them and seeing how we could work as a team to, whether it's providing educational resources, letting them know that we're being safe, letting them know it's okay to get a CT scan. Your risk of death from your cancer was and identifying that progression on the CT scan was very important. And I think the risk of acquiring COVID in the radiology suite was low, and just trying to help them understand the prioritizing there.
Yeah, I'm going to say this. I think that's great. I would just say that especially in the risk of disparities, the attention this country's having towards disparities in lung cancer care now, I think this becomes even more important in a heightened aspect. Hopefully, COVID-19 and the fallout from all the social issues in the last year, which are still quite inflamed right now, highlights the need for addressing those disparities and reducing the burden of all kinds of issues and barriers to healthcare.
Yeah, I mean, I absolutely agree. And that certainly comes into the utilization of telemedicine and health, and in continuing to ensure people who maybe don't have access to that know that we are still here and that we are able to continue to facilitate their care was certainly an important message. When it comes to vaccines, I know that when I got my first one, I cried. I know when I got my second one, I felt a sense of rebirth. And so it really did change my my attitude. I think my family liked me better after I'd gotten my vaccine as well, because I was nicer and more calm. So it's been a real special thing for me to know that I'm vaccinated. I think that the challenge is we're already into vaccinations, and when are we going to need a booster? But I think that we now have 3 COVID-19 vaccines that are authorized, with some adjustments today based on a slight hold. There's a lot of debate about how to time up these and discussion. Is it safe for my cancer patients? How should they time up with therapy? Also, our patients that are on clinical trials. I will tell you that we are, as well as many experts, recommend that most patients with cancer be vaccinated. We are helping guide our patients. I would say that all of the clinical trials in which I have patients enrolled have provided guidance, and no one has placed a block on our patients, even in phase 1, first in human trials, to receive their vaccines. So that's certainly very exciting. I think we've just timed up a little bit different, because when they have their symptoms and we don't know, is that an infusion reaction? Is it a neutropenic fever, or is it a reaction to just the vaccine itself? That has led to a lot of challenges and a lot of phone calls at night when we're on call. But we're more willing to work through that than to deny somebody that opportunity to be vaccinated.
Right. I think this gets at sort of that risk population. I think we've got to be very vigilant and proactive, but we have to do our best to be stewards for our patients through all that. So with all that, I guess we've covered sort of the journey. We talked about screening. We're kind of getting back to recovery, but the fallout from the drop in screening will be, something that we'll feel for a while around, and especially as the pandemic moves. That the presentation of the symptoms of cancer and the workup can be definitely altered by all phases of the pandemic and the symptoms of both of getting COVID, recovering from it, the long effects of COVID that may linger for a while, and all the aspects, as well as the risks of any diagnostic procedures. But even then, we are advancing tremendously in terms of diagnostic and staging procedures, being as consistent with the guidelines as possible. The guidelines that we are still sticking with the guidelines right now, trying to do biopsies sooner, trying to be safe, trying to get people through this through this complex maze of care. But we're working pretty hard to get through that. Requires multidisciplinary care and treatment, and then the treatment is definitely evolving. There's a lot of promise here in lung cancer treatment options for a variety of different stages and different and hopefully personalized treatment options. And then monitoring and follow-up is going to look a little bit different. I think moving forward in the pandemic, it's looked different last year. It's going to look not the same as it did prior to COVID, but I think it'll be an interesting aspect that we learn to incorporate virtual care or telemedicine, other ways to monitor patients, to follow up with them. But hopefully this has tightened up our ability to communicate and emphasized what I think a lot of us took for granted, which was the idea of being able to be there for our patients at any given time. So hopefully the newer tools, the newer technologies will help us with all those aspects. And at this time, we have some questions from the audience. The first question, Katie, would you say is the effect of the COVID-19 pandemic on multidisciplinary care? What are some challenges that you particularly see with the pandemic?
Yeah, I think, I missed, I felt like the biggest challenge was in the height, really relying on that multidisciplinary discussion to say, can we do radiation every day, Monday through Friday for 6 weeks, and get them into the infusion? There's so many touch points, and do a site of chemotherapy. Are we sure that this isn't something that we can resect? And because maybe that's actually easier. Maybe it's easier to come into the hospital. And that was such a scary thing to discuss at the time. I think the challenge was really making sure that you were engaging all disciplines to make some very challenging making some challenging decisions when you really were not sure what was the safest. You knew what was the best, maybe from an oncologic perspective, but what was going to be the safest. I think that for me, the benefit was seeing all of our other offices feel the engagement with the virtual component, and not being just the person that's the one person on the virtual meeting with everybody else in a room. The fact that everybody was equalized on that virtual capacity really allowed for every person to have a voice. And I think that that's something that was a strength in being able to do that.
That's great. So, a lot of us, in pulmonary, a lot of us also work critical care, and many of us were repurposed to critical care who may not have done a lot of ICU time. So we were frontline in the pandemic, and a lot of our other colleagues in the lung cancer space were virtual. And so one of the times we were kind of put up there in the front to sort of communicate all aspects of the multidisciplinary teams care, just by being patient facing and forward up front there. So when we discuss diagnosis, we discuss prognosis, we discuss what surgery or radiation looks like, would you rather have us, you mentioned hand the baton, or in this world, how do you envision us kind of delivering that for those of us who are patient facing and other stuff, and this moving forward from here? Like usually there's been a hand of the baton or a consultation with the so-and-so physician. How do you envision that?
I think I one of the things that helps a good pass of the baton, so to speak, is the utilization of guidelines. And I think that if we're going to pass the baton, I think that we can facilitate that better if we know the expectations of the next person on the track. And one of the ways to do that is through having, whether they're pathways or guidelines that really state, here are the expectations of the oncologist. By the time they get to the oncologist, we would love for them to have that brain MRI and ordering the PET scan or whatever that may be. And so I think having those expectations has allowed for that to be an easier pass, so to speak. What's important to me, is still communicating and knowing, hey, I'm running into an issue. This person is about to start immunotherapy. They just finished radiation. I'm worried about pneumonitis. Can you just be present, right? I mean, it's not necessarily that I need the guidance. It's that I just don't want you to step so far away.
Right. No, that makes a lot of sense. I think that'll be interesting. And so I think the idea of kind of helping people through anticipating the next steps, being guideline based. Now, I'd also add I think you're kind of getting at is almost hyper communicating. That you can't under communicate, especially when people are in this midst of the pandemic. I think it's taught us that we need to open our channels of communication in other creative forms, ideally as well.
And I think I would add to that is just make sure if there's a hyper communication to make sure, who knows who has the action item. Right. I mean, one of the things that gets lost in that is who's really in charge, who's taking that on, so that it's nothing lost in that translation or in that communication.
I agree completely. Well, that wraps up our webinar today. I want to thank everybody for taking the time to come today. It's been a pleasure on behalf of CHEST. It's been an honor and a pleasure to be your host and moderator. And Dr. Milam, Katie, thank you so much for your time and your expertise in this. This is sponsored, as mentioned earlier in the program, was sponsored by AstraZeneca. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have any comments that could improve the delivery of our promotional educational programs, please contact AstraZeneca directly at 1-800-236-9933. Again, thank you so much, and we look forward to your feedback and hopefully you'll participate in more webinars. Take care. Have a great day, everybody.